Time. All right, I'm Dr. Ara Deuk, and we are here at the Surgery Center of Viera. I'm with my team, right? And we're getting ready to do a Deuk laser disc repair on a patient who has been suffering with back pain and bilateral leg pain. So this patient has stenosis, or narrowing of the spine, at L4-5 and L5-S1. He has failed conservative treatment. Conservative treatment usually includes therapy for 6 weeks, medications, injections sometimes. That's pretty much it, huh? And when patients fail to get better, they become a surgical candidate. So there are many different surgeries that can be done, and winding the clock back historically, a couple of hundred years, we were doing laminectomies, probably about 150 years ago or so. That was the original, and now we're doing endoscopic surgery. So there's been an evolution of technology, and as long as the technology is applied properly to help the patient, it can be quite advantageous to having some of the newer techniques done rather than the older stuff. So in this patient's case, we're doing the Deuk laser disc repair at L4-5, L5-S1 bilateral because he has bilateral leg symptoms. Are you there, sir?
Yes.
All right. Our patient's awake. He's going to be awake for a little bit until we get everything where we need to be, and then we're going to put him to sleep. All right, you're going to feel a little stick and burn. That's the needle going to put some numbing medicine, okay? I'll make you a deal. If you feel any pain, say ouch, and I'll give you more numbing medicine.
Okay.
Just don't move your body around, okay? All right, this is going to be, that's my finger pinching you. You're going to feel a little stick and burn. That's normal. You all right? I'll let you know if we have a problem, okay? I promise. And honestly, I don't expect any problems. But I'll let you know if there is one. But you'll feel a little poke once in a while. You just say, ouch, and I'll take care of it for you, okay? All right. We injected 8 milliliters. So the first thing we do is we're going to, after prep and drape, we're going to, and timeout, we're going to numb up the skin. And we've already done the timeout, by the way. I did that before I came in. Of course, we respect all of our patients' privacy. Our patients give us permission to broadcast. And they understand that there's still privacy that we maintain, but that this allows other people to learn from their experience. And what better way to learn about spine surgery than to be involved in a live stream, right? So I'm going to ask my staff to take some pictures, okay? Can you hear me, sir? And I'm going to tell them shot. What shot means is take a shot. Take a picture. All right, lateral. I don't know. It's something that I learned as a resident. And I've just never learned to say something else. I could say Mickey Mouse. I could say squirrel. I could say Santiago. There's lots of different things I could say. But I guess I'm a little bit of a creature of habit. That's something about surgeons, you know. Surgeons are creatures of habit. Did you know that? It's okay. He's resting. I don't want to bother him. But are you comfortable? Shot. A little bit comfortable, or AP, or not? You're okay? Up, fluoro shot up. You can see the tip of the needle coming in. It's actually on the patient's right side. It'll be on the right side of your screen. And we're aiming for the L5-S1 disc because we're doing 2 discs, the L5-S1 disc and the one above, L4-5. We're going to be putting 4 needles in, and we'll do a discogram, and then we'll get started on the actual laser surgery part. lateral. So right now the tip of the needle is in perfect position for where I expect it to be. We're in the foramen and we're about to hit the disc herniation, and I'll feel the herniation with the tip of my needle. It's pretty typical and it's pretty firm and bouncy. The main thing is I just don't want to. Are you comfortable? You feel any pain? Shot. Is that it right there? Main thing is I don't want to, if we get the nerve involved, I want to know right away, right? So I'm giving away all my secrets again, but long story short, if you're going to do this type of surgery, what we're going to do, next incision. I shouldn't have taken the stylet out. I threw you, Luis. Okay. I'm glad you have the 11 blade this time. So if you're going to do this type of surgery, which I believe this is going to be the standard of care for herniated discs in the neck and back, this surgery you're watching right now, the Deuk laser disc repair, the one that I pioneered, will be, in my opinion, the standard of care as long as medicine moves in the right direction. Now, there are several things that would keep medicine moving in the right direction, and the most important is greed. And the reason I say that is that you'll notice from watching the surgery here, we're not going to put any metal in this patient. Unfortunately, spine surgery right now in 2019, and for the last 20 years, as a matter of fact, has been controlled and dominated by large companies that make implants. These implants include screws, rods, cages, and they've basically have created a scenario where spine surgeons are not being taught treatments like the one I'm doing now because there's no implants being put in the patient. So there's no money to be made by the big companies. I hate to say it, but that's the truth. So the big companies are basically stymieing the spread of technology such as this endoscopic surgery I'm doing right now, the Deuk laser disc repair, because they want to keep making their big profits of billions of dollars a year from selling screws and rods, even though it's old technology and it really should be phased out. The Deuk laser disc repair you're watching right now in the year 2019 could replace, I saw an article the other day, there's about 500,000 fusions done in the United States. And the Deuk laser disc repair procedure you're watching right this moment could replace literally 90% of those fusions. So there would be 90% of the spinal fusions that are going to be done in the future endoscopically, just like I'm doing right now, without any metal, without any fusion, and with literally the best results in the world. So, what kind of results, you ask? This surgery you're watching right now, I've done 900 in 13 years. Shot? I need an AP. We've had 0 complications in 13 years. 0. 0 intraoperative and postoperative complications in 13 years. There's no spine surgery in the world that has that record besides the Deuk laser disc repair. So no complications and a success rate of 92%. All right, so right now my needle is looking good. I'm entering the foramen again on the right, but this time at L4-5, which is the disc above. You can see the pedicle of L4, the pedicle of L5, a little more wide. And the spinous processes are on the midline, which is what we want. So this is perfect. Dr. Santiago is right so far. No hitches. Lateral. All right. So it really bothers me. I got to be honest with you. It really bothers me that most people don't have access to the surgery. Okay, the only way you're going to get a Deuk laser disc repair in 2019 is at the Deuk Spine Institute. So let me think about this. The spine must be rotated if the needle is where I saw it on the AP, right? The needle is where I saw it on the AP. It's medial, and we want to be a little bit lateral. So I'm going to redirect. Are you awake? Yes. And this is the part I really need the patient's help. Because as I enter the foramen, there's one thing in the foramen two things actually, but one in particular that's really something that you want to avoid touching. Anybody know what that is? Huh? Sir, do you know? I was hoping. What do we want to avoid getting into when we go inside your foramen? You're going to give him a hint? Huh? The nerve! Hey, hey, hey! This is the first time in the history of the world the surgeon has asked his patient a question about anatomy during surgery while the patient's having surgery, and this patient got it right. The nerve. That's it. This is history. I love it. So our patient's awake. For those of you, you gave him a little bit of a help. That's fine, but he got the right answer. Okay? He didn't have to trust you and believe you, but he did. Shot. That's it right there. Is that it? Oh, so it's further back. Is he moving? I think he's moving a little bit. I wonder if we could get this side down a little bit. Sir, are you able to move your body a little bit and maybe just turn a little bit to where your right side? No, the other way. Yeah, that's it. And can you get comfortable there? Are you able to stay there? That's a little too much. Maybe go back just a smidgen. All right, that's good. Right there is perfect. Shot. Good. That's better. All right, I'm sorry to make you move. Let me know if you feel any discomfort. And this is a big herniation. I'm already on it. Shot. I can feel it. Are you comfortable? All right, so getting back to making history. Deuk Spine Institute has made history in spine surgery probably over 50 times with the surgeries we've been performing here in the Surgery Center for the last 5 years. And of course the Deuk laser disc repair, which I've been doing for 13 years. We were the first in the world to do outpatient spinal fusion in the lower back, open spinal fusion, 1 level, 2 level, 3 level, 4 level, 5 level. First to do osteotomies of the spine, Smith-Peterson osteotomies in the lumbar spine, open, and patient goes home same day, like within 2 hours. I mean, so many firsts, I can't even begin to tell you. Unfortunately, there's no trophies, otherwise we'd have a wall full of trophies. Are you comfortable? All right, so remember, we numbed this side up already, and now I'm just going to gain access to the disc space. So the reason I'm doing what I'm doing is we're creating a path, a safe path, to get from out here, the world where we are, to the disc herniation, where he needs me to fix. So to do that, we use a needle, okay? A needle. And as I put the needle in, I'm also giving him some medicine, okay? So I'm giving him some medicine so that he can be comfortable while I do the surgery. I don't want him suffering. Shot? Yep. I don't want him in pain. But at the same time, you don't want to numb up the nerve either. So we don't want to anesthetize his nerve. Otherwise, he won't feel anything. Shot? And that's not our goal. Our goal is not to get him to not feel anything. Our goal is to to do the surgery and decompress the nerve root safely. I can't help but wonder. These lines don't look right. Look at the iliac crest over here, and then here is different. I think I need to be lower. Num num for the skin. There's epi, right?
Yeah.
I'm going to do a little more loco. I'm going to just put a little more numbing medicine. So 10 cc's went in total. You see how that little thing has to be there, right, Luis? Like this little nose right here has to be in that slot, in that groove. Are you comfortable, sir? So our patient's comfortable, passing through the fascia. Shot. And I've got to get to L5S1. By the way, L5S1 is the hardest level to get to. Most surgeons don't do it, can't do it. The ones that do endoscopic surgery, shot, they won't even try because it's so difficult. Huh. I wonder if his iliac crest is higher on this side, my friend. It may well be. Shot. Huh. I don't know. I think it looks okay. Could I be at the facet joint already? Shot. 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 Are you still okay? Shot. Go ahead and give me an AP. Still comfortable? All right, so this side's a little more challenging. Yeah, we're too far away. Yep, too far away. So we need to be a little bit closer. There's that anti-inflammatoriness of his, right? How's blood pressure? Good? Yeah. So he's not really rotated at 5-1 on the picture that we can see. I just need to be able to get a little bit lower. We have all of our patients stop their any kind of medicine that would quote unquote thin the blood. They stop that medicine usually a week before their procedure. Shot. I don't think I need more local. I just need to get this thing going in the right direction. Shot. Shot. All right, let's go lateral. All right, do you have the AP still up? That's it there. So I'm entering the foramen. The lateral shows that I'm entering the foramen. I would like to be lower. So I'm going to try to get down lower. Shot. Let's see if I can keep this trajectory. You feeling anything at all? Huh? Shot. Yes? That's it there. I want to go lower. Nothing? I feel like I'm on the disc herniation. Let's go AP. Let's see where we are. So another advantage of the Deuk laser disc repair surgery, you're watching over the open surgeries that are done like laminectomies or infusions for this kind of problem, or microdiscectomies, is that our patient's actually awake. Go back to a lateral. And why is that important? Well, anytime a patient's under anesthesia, the time under anesthesia is very important. The longer patients are under anesthesia, the higher the risk of bleeding, complications, bad things happening. So by having the patients awake for really a good part of the surgery in the beginning is really helpful as well from the anesthesiologist standpoint. Shot. All right, we made it. So we have one more to place, and that will be the patient's left side at L45. Remember, we're doing a bilateral 4-5-5-1. So why are we doing both sides? For those of you who have seen me do this surgery before, you may be wondering, why are you doing both sides, Dr. Deuk? The answer is simple. The patient has pinched nerves and leg symptoms on both sides. So he wants both sides normal, And that's what I intend to give him. So I can't do that usually with a one-sided surgery unless the patient's symptoms are minimal on the contralateral side. So when I'm dealing with the lumbar spine, if a patient has left leg pain, sciatica, on the left side, I need to go on the left side. However, Sean, in the cervical spine, when the patient has left arm pain, I usually go on the right side. Sean? So the reason is that just the way we do the surgery is different for the neck and the back, slightly different. And the necks we want to go on the opposite side, Sean. And the backs we want to go on the same side as their extremity symptoms or findings. Another thing that I found quite common over the years in treating patients with herniated disc is that many times patients won't even know they have a problem. Sean? So it looks like I'm a little too high than I want to be. So I'm going to come out. I'm going to redirect. See if I can get a little bit lower. Shot. Zach, any questions from our audience, or should I just keep talking? No, that's nice right there. There's should be hitting the facet right there. Shot. All right, let's go AP. Zachariah.
We do have one viewer who asked, why does the patient need to be conscious?
Great question. Why does the patient need to be conscious? So, 2 reasons. Number 1, I need them to tell me if I hit their nerve in the foramen. That's the truth. Sounds horrible, but that's very, very important. Because if I go through the nerve, shot. Let's go lateral. If I go through the nerve with my needle, they'll feel it. If I bump the nerve with the tip of the needle, just bump it, they're going to say, ouch, it hurts down my leg. I get something down my leg. At that point, if I just stop and redirect the needle to another direction away from the nerve, then there will be absolutely no nerve damage whatsoever. The patient will have a perfectly normal nerve. However, if I pass through the nerve unknowingly with the needle, I felt the herniation, by the way. Do you feel it? Where do you feel it? Where do you feel it? Not down your leg. You see that, folks? That's the exact reason why. He said, ow, ow. And I said, where do you feel it? He said, in his back, not down his leg. So if it was down his leg, I would say, okay, stop. Let's pull the needle back and let's redirect the needle. All right, but I know I can see where the nerve is going to be, and I can see that I'm really far below it. So, but sometimes you're wrong. You know, people have a twisted spine or a slipping spine, and it moves the nerve out of position, or herniated disc will move the nerve too. If you have a herniated disc, it's going to push on the nerve, it's going to move it out of normal position. So having the patient awake to tell me you're not hitting my nerve while you're putting that needle in is very important to this procedure and the success of it. So the other reason is by having the patient, where do you feel it? Not down your leg. All right, that's one of your bad discs. I think I found your bad discs, okay, Sean? And once I confirm that, we're going to put you to sleep, okay? So we're getting ready to put you to sleep. Why don't you go ahead and get comfortable? Just lay still. Remember, we had a deal. You're going to lay still, and I'm going to give you numbing medicine, okay? All right. So we're about ready to put you to sleep, but I just need to confirm that we're in the right place. Go ahead, Sean. How bad is that on a scale of 1 to 10? How's the highest it gets?
How bad is that pain?
8. So this will be L45 is 8 over 10. You got that? Concordant. Is that the pain you typically get in your back?
Yes.
It's concordant. So he said yes. So folks, that's the other reason we need the patient awake, right? So number 1, to make sure that the surgeon doesn't accidentally hit the nerve and damage it. That's the most important reason. Number 2, for the patient's own safety, because this way he's maintaining his own airway, protecting his airway, not going to aspirate, vomit and aspirate, anything like that. Whereas when he's sleeping, he can't protect his airway. And number 3, so we can do the discogram and confirm we're in the right spot to help the patient get rid of their back pain. So our average relief of patients' back pain is 92%. And if you go out 6 years, it's actually 95%. That's our average relief of back pain in all of our patients that have Deuk laser disc repair. How bad is that on a scale of 1 to 10?
No?
Yeah. How bad did that get right there?
About a 6 or
7
7.
out of 10 at L5S1. Is that also where you have your pain typically? Huh? Yeah, it's coming out the other side. You can see that. You see it? All right, you're going to go to sleep now. So we got concordant 4-5, concordant 5-1, 8 out of 10, 4-5, 7 out of 10, 5-1. And that's for back pain. Okay, we haven't even talked about leg pain because his legs are bothering him a lot. Can you count out loud from 1 to 100 by ones? Count out loud from 1 to 100 by ones.
2, 3, 4, 5, 6, 7, 8,
All right, we're going to get started.
9,
We're going to place a guide wire,
11,
L5S1, right side. You're doing great. Everything's going perfectly well. Shot. So now I need a good shot.
18,
So we got our guide wire in. I'm going to take the spinal needle out.
21,
We can put our patient to sleep now, which is
23,
the reason he's counting out loud is we want to make sure he still remembers how to count in English, which he does. I'm just joking.
8,
We want to know when he goes to sleep, so he'll stop counting when he's asleep.
30,
Keep going. You're doing great.
31,
That way the anesthesiologist can titrate the propofol and give him just the right amount based on his response, rather than slugging him up, possibly over-sedating and losing the airway. Patient stops breathing. Bad situation. This way it's controlled. I learned it from Dr. Albert Roten. One of the things that Dr. Roten taught me, who was a chairman of neurosurgery at University of Florida in Gainesville, which is one of the top neurosurgery programs in the world, while he was chairman. Sorry, Dr. Friedman, but it's the truth. Don't hate me for it. Sean? Of course, Dr. Friedman's retired now as well from chairmanship.
We have a question.
Yeah.
We have a viewer asking, what are the potential complications for this surgery?
So one of our viewers is asking, what are the potential complications, Dr. Deuk Majin? Like, what could go wrong? You could die, number one. Number two, you can have brain injury, you can have a heart attack, stroke, you can have aspiration pneumonia, you can have nerve damage, spinal fluid leak, recurrent disc herniation, though I don't consider that a complication. It would be after surgery. Is that it? Right there? Infection is another one, right? You want to worry about. Failure to relieve patient symptoms, I consider a complication. All right, it looks like we're entering the disc space through the tear. I'm going to take the guide wire out now, and I'm going to finish advancing. Shot. The dilator. All right, that looks pretty good. And what I'm going to do next is I'm going to bring our tubular retractor. So, you know, I mean, literally the list of complications is probably as long as my arm in 7-point font. You know, patient can go blind. I mean, there's so many things that can go wrong in surgery. That's why it's so important that you really weigh carefully where you go for your spine surgery. Deuk Spine Institute has literally the best record in the world for spine surgery. We do every type of surgery, non-invasive, invasive, pain management, interventional pain management, blocks. We do it all here. Anything to do with the spine we're able to do. We have our own MRI scanner, an x-ray machine, and our complication rate is lower than anywhere in the world. For Deuk laser disc repair, the procedure you're watching, it's 0 in 13 years, 900 cases. All right, so the whole surgery, can you see this, Zach? Can you see this tube? The whole surgery is done through this metal tube. It's called a tubular retractor, and it's 7 millimeters side to side. So I'm going to slide it down, from our world down the rabbit hole and into the disc. And then when I get it in position, I'm going to take that dilator out. I'm hungry. Is it lunchtime yet? Yeah. It is? Oh, shoot. I'll see you guys later. So, once I get this tubular retractor in shot, then I'm able to take the dilator out shot. And we're going to do the case without the dilator in there. So it's not possible to do the surgery with the dilator in there. I don't know if I answered your question completely about complications. If there's a specific complication you're interested in, I could tell you. But there's so many potential complications of surgery. And the complications of this surgery compared to every other spine surgery, the potential complications are virtually the same, minus the implant failure and the fusion failure, because we're not putting any spinal implants in. You know, I can tell you, people are watching the surgery. Every other spine surgery done almost these days is literally, they put a piece of plastic or metal in that stays in. And there's no need for any of it. All of it, the surgery can be done all natural, no implants. It's a Deuk laser disc repair. That's what we do here. I do implant surgery as well. As a matter of fact, 2 days ago, we did a lumbar fusion with screws, rods, cage, cross-link, bone graft, you know, the whole 9 yards. Patient's doing great. He's actually at home. Went home 2 hours after his surgery. And, you know, we can certainly do implant surgery here. I'm perfectly capable of doing it. I've done 1,000 lumbar fusions in my career. I've done 1,000 anterior cervical fusions. I stopped counting after 1,000, by the way. And hey, he's moving. And I've done about 400 posterior cervical laminectomy infusions, which is another big surgery. We do all those surgeries right here at Deuk Spine Institute. Outpatient, meaning you're going to go home 2 hours after your surgery. Right? That's fantastic. Everywhere else in the world, those surgeries are done in the hospital, and they put the patient at risk of getting an infection at the hospital, which you don't want. Nobody wants a spinal infection. We're inside the L5S1 disc, by the way. This is part of the annular tear. I can tell you right now it's extremely firm, very, very tough. And we're going to put the laser in because the laser is literally the best tool in the world for dealing with these, what is called an annular tear. For those of you who don't know what an annular tear is, you see that the patient just coughed and a bunch of air bubbles came out. Are we ready? So an annular tear is the heart of a disc herniation. Without an annular tear, you don't get a disc herniation. And what the annular tear actually is, how are we doing, Dr. Santiago? Yeah. Thank you. The annulus fibrosus is a tough coating around the disc. It has a soft jelly center. And that tough coating gets torn, and then it lets the soft jelly in the center out. Wipe.
We have a question.
Sure.
We have a viewer asking, can the patient's back
I
pain...
cannot hear you. You're going to have to speak a little louder.
We have a viewer asking, can the patient's back pain originate from the pressure on the nerve locally, or is it due to the injured tissue of the disc, or is it both?
Oh my gosh. Who are you? I love that question. Thank you. So one of our viewers has asked, I think, a phenomenal question. I think we're a little bit overexposed. Let's bring it down one notch. So the question you're asking is, can back pain come from a pinched nerve, or is it from the annular tear only? I think that's what you're asking. I could be wrong, but if it is, then just re-ask the question. The answer is the back pain comes from the annular tear, not the pinched nerve. It never, ever, ever, ever comes from a pinched nerve. That's, I don't know how to call it. I wouldn't call it a lie. A lie is strong, but it's a misunderstanding that even surgeons don't understand. Spine surgeons think pinched nerves cause back pain. Spine surgeons think pinched nerves cause neck pain. So they tell their patients that, and it's absolutely untrue. When you pinch a nerve right here where we are, it causes leg pain. It doesn't cause back pain, it causes leg pain. And when you chemically irritate a nerve, it causes leg pain. So involving the nerve root, dorsal root ganglion, the sheath around the nerve called the dura, any of those structures, whether it's compression, as you're talking about by a herniated disc, or bone spur or ligament, whether it's compression or facet capsule or facet joint, all those cause compression. Whether it's compression or it's chemical irritation, which is the inflammation from the herniation causing getting onto the nerve root. Whether it's either of those, compression or inflammation, it doesn't matter. They only causes leg symptoms. The only thing that causes back pain is the annular tear. And I'm literally the first person in the world to describe that. And it's very important to understand. And the reason, and I'll say it again, but I've said it before, is that the annulus fibrosus, the outer covering of the disc, has a nerve supply, all right? It comes from a nerve called the sinovertebral nerve. The sinovertebral nerve comes from a sensory branch within the foramen, okay? It's called the dorsal ramus. The sinovertebral nerve wraps around through the foramen, around by the facet joint, and wraps anterior to the facet joint and innervates the annulus fibrosus. Specifically the annulus fibrosus in the back of the disc and a little bit off to the side, on both sides. So basically the back of the human intervertebral disc is innervated by the sinovertebral nerve branches. And that nerve is something called a somatic afferent nerve, which means it carries sensory information about pain to a part of the brain that has a very sophisticated map. We call it the somatosensory cortex, primary somatosensory cortex. It has basically a small man called the sensory homunculus pattern, like a map on the surface of the brain, and the fibers from the sinovertebral nerve go up and transmit pain information from every part, actually from the sinovertebral nerve, from the intervertebral disc, where it's coming from. But somatic afferent fibers transmit information. This is too tight. Transmit information to that sensory homunculus that provides our consciousness, our brain, our consciousness, with very specific localized pain. Okay? So there's really two types of pain you can think about in the human body. There's the pain that is vague, discomfort, maybe abdominal pain. You can't really feel it in one spot. And then there's sharp pain, right? So there's vague discomfort and there's sharp pain. Vague discomfort is transmitted to a different part of the cortex, the sensory cortex, where there's no somatotopic localization possible, where your brain can't figure out exactly where it's coming from. That's why it's vague. And the rest of the spinal disc, the lateral and anterior part of the annulus, has that visceral afferent, which is vague sensations of pain, which people really don't feel at all, right? I don't know, the pathways are just not as well developed. Standby laser. But the back of the disc, where these tears are that we're fixing right now, these back of the disc tears actually are transmitted through a different pathway to the brain that goes to a map on the brain that lets the brain know exactly where the pain's coming from. So it's highly localized pain. That's why it hurts so dang much when you have a herniated disc that causes pain. It's always in the back of the disc, never in the front, never in the sides. You never find us fixing back pain by operating on the front or sides of a disc. Now that being said, maybe there's an opportunity here. Maybe there's subconscious pain. Pain that doesn't reach conscious levels, but it affects our mood and it affects our behavior. It affects the way we experience life, and maybe that's something for the future. Maybe that's something that my children will discover. Pain pathways from the lateral and front of the disc that are transmitted to subconscious areas of the brain and that affect our mood or our quality of life in some way. That's certainly futuristic. But for those of you watching this broadcast, fixing back pain today in 2019, the future is here. We're able to fix that sharp pain that you all feel in your neck or back, no problem. Very easy to do. But when I say we are, I don't mean all spine surgeons and all pain management doctors. I mean Deuk Spine Institute is. So if you want to have the best care in the world, you come here and let us figure out where the pain's coming from and then let us fix it. We have a treatment that's minimally invasive for every single source of back pain or neck pain. You don't have to have an open fusion surgery. We're able to fix the pain now without open surgery by doing endoscopic surgery or by doing a needle procedure called a rhizotomy or a joint injection with PRP or stem cells. All right, you have another question there, Zach?
Not yet.
All right, so I think I answered the last question pretty thoroughly. And the answer is pinched nerves never cause back pain or neck pain. They only cause leg pain or arm pain. And numbness, tingling, and weakness in the arm or leg. So numbness, can't feel areas of your skin. Tingling, I feel pins and needles. Weakness, self-explanatory. The worst type of weakness would be a drop foot, where you can't cock your foot up in your lower back and you're dragging your foot. That's going to make your life miserable. So don't let it get to that point. Get it fixed before it is. Now right there is granulation tissue. It's pink. You can see it. It's right in the annulus. That needs to be zapped away. That's the source of a lot of the patient's pain. I can tell you right now from while I've been operating, I can tell you right away that this is extremely scarred up herniation. Lots of inflammation. In other words, this patient injured his disc many years ago and probably has had repeated injuries over the years where he's re-injured the tear and created more inflammation. Remember, your body's response to these tears is to make inflammation. Right in the disc, right here where we are today, right where we're looking at. And all that inflammation for all those years has been going on right here within the annulus fibrosus. And what's causing that inflammation is the herniated nucleus pulposus. So the jelly from the center of the disc, standby laser, has squeezed out through the tear and is causing inflammation in the annulus, and that inflammation is being felt by that branch of the sinovertebral nerve we talked about, right? And that pain signal from the inflammation is going up to your brain. And that's why there's back pain or neck pain. So we've worked out the pathways at Deuk Spine Institute. We know how the pain gets to the brain, where it goes in the brain. The nice thing is that I am a brain surgeon, so I actually know these things. Unlike other types of doctors that treat pain of other specialties, that don't have the training that I have as a neurosurgeon. So their understanding of these pathways is not as thorough. But my understanding of the pain and the pathways has allowed me to figure out what causes chronic pain in patients from disc injuries or facet joints and how to treat them and fix them. Deuk Spine Institute is a very unique place. We have some of the best doctors in the world right here, ready to take care of patients with back and neck injuries. Any more questions, Zach, or should I keep rambling on?
Not yet.
All right. Just so you know, there's a bone spur right here to the right. That's bone. Okay, right there. You see what color it turns? Golden when you zap it with a laser. So for those of you who are wondering, I'm using what's called a holmium YAG laser. There are many different types of medical lasers. This is the best for the application of the Deuk laser disc repair. The holmium YAG laser is a safe laser to use. We were talking about it its attributes the other day and what makes it so wonderful. It actually it works well in liquid mediums, which is what we have right here. You're watching. This tube, the tubular retractor, is filled with saline. Is it lactated ringer or normal saline? Do you remember? It's normal saline, and it's cold, so it keeps the tip of the laser cool. It keeps the tissues cool. Otherwise, the laser would be charring the tissue, making it into like little charcoal briquettes, which we don't want. So the liquid, the cool liquid that's going around the laser tip is actually helping to prevent damage to the tissues, which you don't want. So we only want to get rid of the stuff we want to get rid of and not hurt anything else. So whenever you're dealing with something like a laser, you worry about the transmission of heat. Heat, as it heats up the tissues, can be transmitted, from where you're blasting over to something nearby, like a nerve, and you don't want to do that. So it's actually a really good system that we've got in place for managing thermal transmission of energy from the laser. So anybody watching the broadcast that's interested in learning the Deuk laser disc repair or bringing it to their hospital, we are open to this. We are currently creating franchises and want to spread this technology around the world. So if you know somebody who is an administrator at a healthcare facility that does surgery and wants to bring in spine surgery, this advanced spine surgery that we do at Deuk Spine Institute, we're open to meeting with you and talking about how to set up a Deuk Spine Institute at your facility to serve your community so that people don't have to travel. We have patients at the Deuk Spine Institute that travel from all over the world, Africa, Canada, all over the United States, Europe, Asia. They all come here for surgery because of what we do. Nobody else offers this, and we're happy to set up more Deuk Spine Institutes around the world to serve patients. Dr. Santiago has agreed to be our director of anesthesia if that happens, right?
Absolutely. Sign me up.
And do all the training and overseeing of all the anesthesia. But just contact us if you're interested. We have a group in Israel that has contacted us, for example, that wants to bring the Deuk laser disc repair to Israel, to one of the larger hospitals, and serve the community there. So exciting stuff. All right, what I'm dealing with right here is the annular tear. You can see the annular fibers here, the white stuff where my laser tip is. Okay, and you can see that there's a tear right here, and there's this blue stuff stuck inside. That blue stuff is the herniated nucleus pulposus. That's what's causing all the inflammation, right there. And I'm zapping it away, along with some bone spurs right here. These are bone spurs. Goodbye, bone spurs. Okay? So this nucleus material that's stained blue, I can tell it's been there for a very long time, years. It's so tough, thick. It shouldn't be. It should be soft and fluffy. So the fact that it's really tough and thick tells me that this patient's injuries certainly date far back into the past. I would say at least 5 years here with this disc injury. By the way, if you're a work comp adjuster or case manager, the endoscopic surgery is a wonderful way to try to date injuries. I can go inside the disc and I can tell roughly how old the disc injury is. Certainly much better technique than anything else out there that's available. MRIs won't tell you how old an injury is, but an endoscopic treatment like this, I can get into the disc and I can see just how old that injury really is. So we're getting near to being done. We're at L5S1 disc herniation, right side. And Luis, you're doing a great job here.
Thank you, sir.
I didn't even miss Carl, to be honest with you. I mean, I think that's a good thing, right? Carl's not listening. If Carl was going to listen, he'd be here collecting a paycheck listening. You like that? So Luis has taken over Carl's responsibilities. Don't get any ideas about recruiting Luis. Luis is extremely loyal to Deuk Spine Institute, highly dedicated, and no amount of money would ever take him away. Right, Luis? What? $100,000? Wait a second. Can you go off mic here? Just kidding. No, Luis loves what he does. He came to us from Puerto Rico, and he started as a medical assistant. Quickly, we realized he had major, this is the painful part of the disc, major, you want me to stop or should I keep going? Yeah, it's fine. I don't mind a little movement. If you want to keep him a little lighter, I'm fine with it. But Luis showed us that he was a leader and that he could get stuff done. He actually became the lead of my clinic. So he managed all my medical assistants, and he's done a phenomenal job. But obviously, whoa. So our patient's a little bit light. Standby laser. What that means is he's not as deep asleep as we would like. However, our anesthesiologist, there's a herniation right there, is basically balancing the need for sedation versus safety. And I respect that, and I let our anesthesiologist do what he needs to do to keep the patient safe. I can always stop what I'm doing and start again in a few minutes. How are we doing on irrigation? Oh, this should not be open. What is that? Stupid. But the safety of the patient is number one. Number one, number two, number three. And that's right now in the hands of our anesthesiologist. So I do what the anesthesiologist tells me to do at this point. I don't want to harm the patient in any way. And the airway and cardiovascular system is the most important thing to protect besides the brain. Thank you. Yeah, thank you. Okay, so we've got a little bit more to go at this disc, and then we'll be done. And we can move on to the next. I'm just about done right here. I just want to try to get some more of this blue herniation out of the annulus. That will allow the annulus to heal. We want this annulus to heal, by the way. Yeah, he's moving. And I'm fine with it, as long as you're okay with where he is. I'm almost done here. The key is, it's the annular tear right here that causes the back pain. And if I can remove this material, the back pain will 100% go away. Okay? If I don't remove this material, the back pain will not go away. It has nothing to do with the nerve, the big nerve coming out the hole next to this. The big nerve coming out of the hole has everything to do with his leg symptoms. And I'm going to check that nerve to make sure we got all the pressure off. But I've taken all the herniation out. I'm seeing epidural fat now. That's the stuff up there at 12 o'clock. And I'm pretty much done. I'm outside the disc, or just about outside the disc. The laser's still cleaning up the annular tear.
We have a question.
Sure.
We have a viewer who's asking.
A little bit louder, Zach. I'm sorry. Maybe
Yeah.
you can turn the volume up a little. Yep, go ahead, Zach. I'm listening.
We have a viewer who's asking. I am overweight and was recently diagnosed with an L4, L5, S1 bulge. Can you work on overweight or obese people? I'm in Washington, D.C., tired of getting multiple answers, tired and in pain for years now.
Okay. So, can you work on obese people? I heard that, but I didn't hear anything right after that. You mumbled it. Can you speak a little bit clearer, please?
Yes, I said, I am in Washington, D.C., and tired of getting multiple answers, tired and in pain for years now.
Yeah. All right. So, first of all, I love obese people, okay? Because I'm obese myself. All right? At least my wife says I am, and I'm sure I am. Fact of the matter is, obesity doesn't cause back pain. I don't care what people say, it's a lie. I don't know why they say it that way, but it's so untrue. Let me tell you something. At Deuk Spine Institute, we had about 40,000 patient visits last year, okay, in 2018. And of all those patients with back and neck pain, many of them were skinny. Some of them were fat. Most of them were just normal weight. But the truth is, it doesn't matter if you're fat or skinny. Back pain comes from a herniated disc, if it's coming from a herniated disc, and has nothing to do with your weight, okay? Now, can we fix an obese person? Absolutely. No problem. We do it all the time. What I would want to know, though, is are you morbidly obese? Because that's a different category, and it's not that we discriminate. It's just that if your weight is over 400 pounds, then our equipment is designed for patients up to about 400 pounds. So I don't know how much you weigh, but if it's over 400 pounds, if you're close, we might be able to do it. When I say our equipment's designed for 400, it's really 450, but I'm not going to take it to the limit. So I tell people 400 because I'm kind of a conservative person. But the fact of the matter is, if you're under 400 pounds, there shouldn't be a problem. Okay? Now, I don't know if I think you said it's your lower back. So this is somebody in Washington, D.C. watching, and they want to know if they can get fixed. They have 2 bulging discs, L45, L5S1. Very, very, very easy to fix. Don't listen to people who tell you anything other than that, because it's not true. Maybe it's true for them. It's probably true for the rest of the world, but it's not true for Deuk Spine. We fix people all the time. And that's why we do the broadcast, by the way, is for people like you, to be quite honest with you. I don't want you to live in pain and suffering your whole life. There's no reason for it. That's why we do the broadcast. All of our broadcasts is because we want the world to know that you don't have to live in back pain or neck pain anymore. It's fixable. But it's only fixable in certain places. Now, I wish it was fixable everywhere, you know. But the fact of the matter is that most surgeons and doctors don't do what we do. They don't know how to do what we do. It's actually easy for us now, but the process and protocols and pathways that we implement to fix people, we've been doing for years now, but they're well established at Deuk Spine, but they don't have them elsewhere. And so let me tell you something. I can't tell you how many people are like you. Like literally countless numbers of people out there that are told they just have to live with it. There's nothing that can be done. And it's just not true. Not if you're willing to travel. I'd recommend you get in touch with Lauren and we can do an MRI review, see what's going on back there. And we'd want to take some history. Want to know where your pain is, which leg it goes down. Do you have numbness? Do you have weakness? So we have staff who do that. And then they present the MRI and your history to me. I listen. I look at your MRI. And then I make a recommendation for what I think needs to be done. And then we have you come out here and we can get it done. So most patients that travel will come in. They'll spend 3 days here. They'll come in and meet me in the office, meet Dr. Santiago, our anesthesiologist. They'll do a medical clearance interview with him and a history and physical and talk about the surgery with me. And if you don't have an MRI, it's okay. We have our own MRI scanner here. It's open and it's wonderful, made in Italy. Probably the best open MRI in the world. And yeah, anyway, we have our own x-ray machine and ultrasound, all kinds of goodies. So we're fully contained. We can help you. Just set up a visit with Lauren. All right, I'm just about done. I'm kind of lateral here in this L5S1. There's just a bunch of grunge right here, and I don't want to leave it behind because it's pretty firm. And I don't want to leave something so close to the nerve root so firm, so lateral. So I'm a very thorough person. I could have stopped after 30 seconds, and I said I did it. But the fact of the matter is I want my patients to do well. I want every single one to be a home run. So that's how I operate. That's how I work. I give my best every single time. All right, I'm pretty happy here. We're in the foramen with the tube. I think I've gotten just about everything I can. You can also see the laser does coagulate blood vessels. So anyway, I'm done. Laser off. I'm going to show you the nerve root just so you can see it, see how close we are. It's going to be just over here. Unfortunately, there's a little bit of fat there, but you can see the vein. That vein is sitting on top of the nerve root. So, and the herniation's gone. All that done through a tiny little cut on the side rather than drilling bone away or removing bone like every other surgeon does to get down to the herniation. We're able to get to the herniation without removing bone. Trying to just suck the juice out, and we're going to be done at this level. Come on. You know, there's a little cap that goes with this. I don't know if you're aware of it. It's kind of gray, Luis. Have you seen it? Oh, my irrigation must still be on. Luis, have you seen it? The cap?
Piece of cap? No, sir.
It's like a little gray cap.
We have a question.
Scope, standby. Yeah, there's a little gray cap that goes on the end. It actually helps suck the juice out. Yes, on the question.
We have a viewer who's asking, what are your thoughts on physiotherapy and chiropractic care in the management of chronic back pain?
Oh, great question. So what are my thoughts on the role of physiotherapy and chiropractic in the management of chronic back pain? Absolutely 100% essential. Yeah, every patient with chronic back or chronic neck pain needs both physiotherapy and chiropractic, okay? And as a matter of fact, that's what we do for our patients. If they come in and they've had chronic back or neck pain, they've never had treatment, we always send them for 6 weeks of physiotherapy and chiropractic. We send them to a chiropractor and therapy group that really knows what they're doing. So, yeah, we do that pre-op, and then we do it again post-op. No, I'm just waiting. Give me a second. I want to make sure I maintain pressure here for a minute. Luis, will you hold pressure? So we're compressing the paraspinous muscle, and the reason we're doing that is just to stop any bleeding that there may be in the muscle. Remember, we didn't cut the muscle, but we passed through it, and sometimes when you pass through muscle, some of the fibers will tear. And if they do and there's a little vein in there, you'll get a little bit of bleeding. All right, shot. 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 I'm looking for the guide wire to come out. Shot. I think I see it. Shot. There it is. Just to make sure. Shot. Yeah. All right. So we're good. You have a blue towel.
Yes, sir.
I just don't like the idea of this. So to answer your question completely, physiotherapy, chiropractic, absolutely necessary in the management of chronic back and neck pain. The reason chiropractors are necessary is the chronic pain actually really comes from joints, and joints that are painful for a long time are painful because of inflammation. Shot? What? Do you understand? So they're painful from chronic inflammation. Well, I got news for you. When you have chronic inflammation in a diarthrodial joint, like a facet joint, you're going to get lots of scar tissue from that chronic inflammation. Shot? So it's really important that that scar tissue get broken up. Otherwise, it's just going to cause stiffness and pain with movement. So it's very important that patients get chiropractic treatment when they have chronic pain, because chronic pain always involves joints. Okay, that's number one. And you want to break up that chronic inflammation and scar tissue that's in there and get those joints moving. All right, second of all, you want physiotherapy because you really want to rehabilitate the muscles. So whenever patients have chronic pain, what they do is they get inactive, and their muscles, their core muscles, their extremity muscles, all that stuff gets atrophied and shriveled up and doesn't work as well. It's not strong. It's deconditioned, we call it. So it's very important that the patients get therapy to recondition their muscles and their ligaments and tendons, and strengthen their core muscles, and all that's done with physiotherapy. Stretch. I also believe in medical massage. So all of our patients get medical massage as well, which is, massaging the muscles. So what I can tell you, if you watch enough of these surgeries, you'll notice that what I'm doing is operating on the spine. I'm not operating on the muscles, okay? And the fact of the matter is, if I do the best spine surgery in the world and the patient has muscle pain after surgery, they're going to have muscle pain after surgery. They're going to be miserable, absolutely miserable. And if you leave that muscle pain, which is really inflammation, going for too long, they get contracture in the muscle. Contracture is really bad. It causes trigger points and whatever, bad stuff. So what I'm trying to say to you is you can't ignore the muscles. You can't ignore the joints. I'll take the hammer, mallet. Tell me when you're ready. Take it. You can't ignore the muscles and joints. They must have therapy. So I tell my patients, every single one of them, before I operate, I'm going to say, listen, you're going to need therapy after surgery. And if you don't do your therapy, you don't do it right, you don't go to the right place, you don't do the right exercises, you don't do the right restrictions, then you're going to end up still having pain afterwards. But it won't be the same pain. It won't be a disc pain. It'll be a muscle pain. It doesn't matter. It's still pain, and it still restricts the patient's life. It steals and saps from their quality of life. So it's very, very, very important. Physiotherapy. Shot. Great questions today, by the way. I love when the audience asks really intelligent questions. Shot. I got to tell you, since if there's another question, I'll take it. Shot. But I know most of you know me as Dr. Deuk, the neurosurgeon that fixes people's back and neck pain. But one of the other things that I do is I've discovered what's killing corals all around the world. And I go online and I try to educate the public about it. Unfortunately, there's a lot of what I call brickheads out there. And what they are is, it's not that you don't know something that you're a brickhead, it's that you don't want to know something that makes you a brickhead. In other words, you want to bury your head in the sand and ignore the truth and fight against the truth no matter what at all costs. All right? So, unfortunately, there's a lot of people out there that are really either bored and enjoy, arguing for the sake of arguing, without really having a purpose or goal that's productive or positive. I call them haters. I think that's what they really are. But the point I'm trying to make is I spend a lot of time online trying to educate the public about a disease that's killing corals, and that disease is a protozoan parasite called philaster. And I discovered it about a year ago in my house because I take care of coral, actually in my lab, and I discovered it with a microscope. So I go online and I sit there and argue with people about the experiments that I ran to discover the philaster is the cause of coral death, and they just continually argue without really even having a serious point. It's a little frustrating. So it's nice to come here and talk to you all about fixing back and neck pain and have people that are reasonable, that really want to get better, and they're motivated for the right reasons to learn and learn what's going on in here and why we do what we do. So, some of you may be watching and you think, well, you're just doing these surgeries, they don't really work. but they do work. We follow up with all of our patients. They don't work 100% of the time. We're not going to get 100%, but we probably get about 99% that they work. And of that 99%, our average relief of back pain, for example, is 95% at 6 years. 6 years after the surgery. Our patients have on average 95% relief of their back pain. So that's an average for the group. That's really, really good. Stand by. Really good results. So I can tell you already, this L45 disc that we're doing right now, we just got into, it's soft, much softer. So what that tells me is it didn't herniate so long ago. At least what I'm dealing with right here deep is a softer herniation, not as much inflammation, but you know, let's see what it looks like when we get to the periphery. But that last disc was like concrete. It was super hard, super sclerotic is what I call it. Lots and lots of inflammation. I like to think of these surgeries also as time capsules, because someday someone's going to come back and watch this video. And currently it's what is today, May 16th, 17th? 16th of May 2019, right? And you know, someone will come along 20 years from now and watch these videos as somebody interested in learning the technique, who wants to apply it to their patients, their practice, and make for better outcomes. And they're going to be listening to everything we talk about. So it really is a time capsule, what we discuss here. It's quite interesting. So when you don't ask questions, I just start rambling on about things that are happening around the world, so that whoever comes by 20 years from now and discovers this treasure of surgery that I've created, they're going to be able to hear about everything else that was going on in 2019, and maybe the world will be a better place. Maybe they'll look back and laugh, right? Kind of like we look back and laugh at black and white television, right? Or back in the day when we only had 2 channels on television when I was a kid. 2 channels, and they were black and white. Stand by. And now we have the internet with unlimited channels from all around the world. I mean, how much life has changed. Maybe for the better. I think having knowledge is good, but there's certainly a lot of ways to waste your time on the internet, aren't there?
We have a question.
Of course, I'll take the question.
We have a viewer asking, if I were to have this surgery, how soon could I go back to work?
All right, so we have a viewer who asks a great question. If I had this surgery done, when can I go back to work? So the answer really depends on what you do at work. The short answer is you can go back to work today or tomorrow, okay? I mean, if you wanted to go back to work today and you have the surgery in the morning, you can go back to work in the afternoon. All right? That's not what we recommend, but I would say the next day is really good. But you could go back to work the same day. We have patients who have done that. Not too long ago, we had the coach of the men's basketball team. I can't say where, but he had the laser surgery in the morning, and then he went and coached the championship game at night. Okay? He can't drive a car the same day, but he had somebody drive him to work, maybe one of his players, and he coached the game. the point I'm trying to make is you can go back to work the same day if you really want to. On the other hand, if you've got a job that requires you to be not without restrictions, basically, if you have a job that says you can't come back to work unless you're completely released without restrictions, then you're looking at probably taking about 8 weeks to fully recover before you can go back to that type of job. So if you have a job that will let you come back and you can do some lifting restrictions and bending restrictions, standby laser, then you can go back to work the same day or the next day. If you have a job that requires heavy lifting, then you're looking at taking some time off or going back light duty. What I can tell you about this L4-5 disc right here is it's smashed up really bad. I mean, it is like multiple. Look at all these fragments, just little chunks everywhere. It was damaged pretty badly. But we're going to repair it nonetheless, and I feel really good. I think this patient's going to do fantastic. But so many little fragments of disc. I don't know what happened to him, if he fell or got into a car accident, but something just crushed this disc. He'll be fine once I get done with it, but it's just a bad injury, and it's relatively recent. I would say probably within the last 2 to 3 years, based on what I'm seeing right here.
We have another question.
Yeah.
We have a viewer asking, do spinal epidural steroid injections for the lower back pain affect surgery outcomes? I've heard from someone having many injections that it can make surgery on herniated discs more difficult.
Okay, so great question. So we have somebody asking Dr. Deuk if somebody has lots of epidural injections in their back, will that affect their spine surgery? Okay, so great question. Great question. And it's tempting to answer it without really diving deeper into the issue. It's tempting to say, of course it won't affect it, right? And you think on the surface it won't affect it, because what they're injecting is a steroid medicine, and steroids are going to wear off. They're going to basically disappear out of your body after a few weeks, okay? But their effect can be longer lasting, but the steroid itself will be gone. So how is it possible that that statement could be true? It could be true for one reason, in my mind. If you get lots of steroid injections, steroids have another effect on your body that most people don't talk about. They have lots of effects. One of them that's concerning, that's bad, is that they weaken your bones in your spine. They can give you what's called osteoporosis. So if somebody who's getting lots and lots of steroid injections develops osteoporosis as a result of those injections being done too many over years, their bones can be very weak in their spine, in which case spine surgery, like a fusion surgery, would be more dangerous, because the bones are weak and you're putting all these screws and rods into the bone thinking the bone is going to hold the screws and rods in place. So that's the only way that I can think that spinal injections with epidural repeatedly before spine surgery would be detrimental. All right. Now, aside from that, would repeated epidural injections over years increase the risk of spine surgery? I don't think so. Not in my opinion. I think it's safe to do. As a matter of fact, look at that. Look at all these herniated discs. It's incredible. Look at that thing. Right? It's just stuck in the annulus. Stuck in there. We call that interposed disc herniation, causing inflammation. Lots of them. So my feeling is that epidurals are good to try, at least one, and you should get 50% improvement in your leg pain, your leg symptoms with the epidural. I don't think epidurals are a good choice for back pain. I think they're a good choice for leg pain. Now, if somebody has a herniated disc in their back and they have no leg pain whatsoever, but they've got back pain that I think is coming from that herniated disc, I would still consider one epidural just to see if that anti-inflammatory effect of the epidural helped with the inflammation on the disc. Because there's probably a 25% chance it will. Remember, our goal is not to operate. Our goal is to cure your pain. But if operation is necessary, that's what we do. Operating becomes necessary when other treatments that are supposed to fix it don't work. So then you get to an operation. There's the tear, by the way. You see the white on the left at 9 o'clock. You see the white on the right at 3 o'clock, and you see a giant tear with blue. That blue is nucleus pulposus stained. So the annulus fibrosus never stains blue. Only the nucleus pulposus can stain blue. That's why you can see where the tear is, because the nucleus is stained blue. You know where the nucleus is. The nucleus squeezes out through the tear. The annulus is white, always white. It's collagen. And what the come on, Luis. Get it together. Oh no, you got to be watching this stuff. That's your little home. All right. Do we have any more questions, Zach?
We have a viewer who's asking, can you remove the buildup of scar tissue in the facets?
All right. Can I remove the buildup of scar tissue within the facet joints? The answer is yes. But you're not going to like necessarily what I'm going to say next. You can remove it surgically by removing the facets. Okay? And we do that. And it works. However, once we remove the facet, we have to put in screws and rods. Okay? So is there another way to treat facet joint pain and inflammation besides removing the facet? The answer is yes, absolutely. The best way in the world to treat facet joint pain is chiropractic therapy. Okay? It's called manipulation. However, so the best way in the world to treat facet joint scar tissue and pain that comes from that scar tissue is chiropractic therapy. However, here's the problem, and every chiropractor knows this. Once you take a patient with facet joint syndrome and scar tissue and pain from their facet joints, you put them on the manipulation table and you start to manipulate them. The first thing the patient's going to do is tighten up their back and guard. What that means is they're not going to let the chiropractor manipulate the joint because it hurts too much. Okay? If my shoulder hurts and you grab my arm and try to pull it towards you, I'm going to resist. That's called guarding. That resistance is guarding. You don't want your shoulder moving because it hurts too dang much. So we have a special way of dealing with that. And that special way of dealing with it is to actually numb the facet joints with either Novocaine or, which is called a facet joint injection, or actually deaden the facet joint for a longer period of time in a procedure called a rhizotomy. Okay? And we do those rhizotomies here at Deuk Spine Institute all the time. So once you get a rhizotomy done, you've deadened the facet joint that has the scar tissue and inflammation, and you can now go to the chiropractor and get proper treatment, which is manipulation of that joint. Yeah, you know why he's moving? Is we're actually in the painful part of the disc once again. We're out near the surface where all the nerve fibers are. Yeah, that's fine, thank you. How much energy have I delivered to this disc, do you know? How much energy have I delivered to this disc? Something like 25. Standby laser. Huh? So less than 22? Oh. How much? Stop grabbing with the same place on that, okay? You just keep putting the tissue back in there. And I keep going back in and releasing it. Simple, just move it a micron and you'll be fine. What do you mean waiting on the laser fiber? You're worried about the laser fiber?
Yes.
Why?
Because I don't see the tip.
It's okay.
Okay.
Yeah. Did we crack the tip off?
I don't see it.
You know how wide that laser fiber is? 0.5 millimeter. 0.5 millimeter. Are you used to looking at things that are 0.5 millimeter? I hope not. All right, take this.
17,150.
All right, so 17,000. That's not bad. Yeah, we're okay. Yeah, you may not see the tip, but it's there. I'm sorry? Yeah, it's fine. I mean, cracked off the last piece, but it's all right. Just be careful next time, and we'll be fine. Anyway, this is called the annular debridement, for those of you wondering. Those of you who are really Deuk laser disc repair fans, okay, which you should all be, by the way. The surgery has really three parts. It has a discectomy, an annular debridement, and a foraminoplasty. I published this back in 2012 in the National Library of Medicine, the United States. National Library of Medicine. It's the highest level of recognition you can get for anything in science. It's a peer-reviewed publication, okay? That being said, I'm not a big believer anymore in peer-reviewed publications because the system is so corrupt. But I did publish several times, still publish. I have more papers that I will likely publish. That being said, this surgery has three parts: annular debridement, discectomy, and foraminoplasty. There's opening up the foramen. You've been watching now for a while, and I would say 95% of what I do is an annular debridement. There's a piece of disc herniation. Okay? Just for reference. 95% is annular debridement. And you can see this disc compared to the last one is more fluffy. It's got a lot less of the scarring. You can see the tear right there, the annular tear. We're just about done. I think probably 5 minutes on this one, though it's hard to tell for sure because there's just so much herniation. By the way, this disc is massively damaged, in case I haven't already explained it. To me, it looks like there was major trauma to this disc. Now this stuff here is older, more scarred. Still could fit within those 2 to 3 years of injury ago. So great questions so far today. We have any more from the audience? Remember, this is a didactic session. I'm here doing surgery but teaching at the same time. And for a variety of reasons. Number one, I can. Number two, I enjoy it. I enjoy teaching and educating people about the truth. And number three, why? Anybody have a reason I'm not thinking of? Huh? To spend time with Luis. Dang, you're right. Thank you, Luis. That was like the most important one, by the way. Stand by. So for those of you watching, this is a live surgery. We don't edit the surgery. You're getting a live stream. Why is that important? Well, you may hear things that we say that we would like to edit, but we don't. That's fine. But the reason we don't edit is simply because I want you all to see the truth. The moment I start moving towards you like that, it means I don't want you to wipe, I want you to take it. You should move your hand to the side and grab the shaft. Okay? It should be a completely different pattern of movement for you. Okay? You know what the black widow spider is? Huh?
Yes, sir. Yeah.
Have you heard of it? What is the black widow?
The black widow spider?
Yeah.
Yeah, it's a very small black.
Uh-huh. Why is it called the black widow?
Kill the husband.
Kills the husband, right? So how does it kill the husband?
I think she inject the eggs inside the husband or something. Or no?
How does she kill the husband?
With the venom?
Huh? Does she stare him down? Does she use a rocket launcher? Handgun?
Inject the venom.
That's right, she bites him. So she has to be close, right? How does she have babies with him? How does she mate with him? Has to be close, right? So killing and giving life, both actions require close contact. So how does the male know when she's going to bite versus when she wants to mate? He pays damn close attention. That's what he does. Right? To every little nuance of the movement of the female. And if she's moving in a way that isn't so, I don't know, reproductive, then he's getting the heck out of Dodge quickly. You understand my point?
I understand, sir.
Pay attention to the details, and you'll know exactly what to do.
Yes, sir.
Just like a male black widow spider.
We have a question.
Yes.
We have a viewer who's saying, my wife is suffering from a lot of pain in her right shoulder, which shoots down the arm and into her palms at times. Is there a way that they can, what's the best way to get the proper diagnosis for that?
Yeah, so fantastic question. Thank you for bringing that up. We have somebody who's saying, I've got a loved one who has pain in the shoulder area that goes down into the hands. And I want to make a diagnosis as to what's wrong. What I would start with is, number one, a good physical exam. So a shoulder problem is pretty easy to figure out with a good exam. I can figure it out within 10 seconds of examining your wife. Then I would order an MRI, standby laser. And an MRI would probably show a herniated disc pinching a nerve. And that's easy to see. So if I were to examine your wife and I see that she does not have shoulder pain with rotation or any of these evocative tests that I would do, you know, by twisting her arm, twisting her shoulder, etc., and I see that there's no shoulder pain, and then I see the herniated disc on MRI, and she shows me that the pain travels from her neck down her arm, then I'm sold. You know, I'll probably get a nerve test, and then I would recommend surgery on the herniated disc or discs. So I think if you're asking what tests would be good, a nerve test would be really good, and a shoulder exam would be good. Now, if I found pain on shoulder movement, like with rotation or palpable tenderness in the area of what's called the rotator cuff or the bursa, then I would get a shoulder MRI to better figure out like what's causing that pain. Like which rotator cuff is injured. Is it, you know, there's four muscle tendons that make up the rotator cuff. So what are we dealing with? So yeah, it's very, very, very easy, to be honest with you, to figure out, is it a shoulder or is it a pinched nerve in the neck? Is it, there is some other weird diagnoses. One of them is called thoracic outlet syndrome, which you should look up on Google and learn about. You know, sometimes you'll get these nerves getting pinched in the neck with the scalene muscles or with an extra rib, and or with a band of tissue that can pinch the nerves as they exit the brachial plexus and go down the arm. So there's a few things that can cause the symptoms that she's describing. Another one is something called Parsonage-Turner syndrome. I don't know the onset of her pain, but if it was sudden onset after a viral illness, it could be Parsonage-Turner syndrome, which is basically inflammation of the brachial plexus that causes pain in the neck going down into the shoulder and arm. So there's a few other diagnoses, but these are really unusual and the most likely diagnosis is a herniated disc based on what you're describing. So, but that's important to pay attention to the details. If you, as a doctor, don't pay attention to the details, you're going to make the wrong diagnosis. I'm going to tell you an interesting story from medical school that has always stuck with me. And the very first day of medical school for me at USC in Los Angeles, University of Southern California, a very, very reputable medical school, one of the top in the country. The head of pathology, his name at the time was Dr. Clive Taylor. Clive Taylor, British chap. He had been the chairman of pathology department at USC for years. I think his co-chair was an Indian doctor. Oh man, with what a name. They wrote the textbook together, and that everybody used for pathology. Well, pathology is probably, in my opinion, the most important class you're going to take in medical school, besides histology and anatomy. Because pathology is essentially the study of disease. And we doctors don't treat normal people. We treat people with diseases. So we had our very first day in orientation. Everyone's sitting. There were 170 students in my class. Everyone's sitting in the lecture hall, and Dr. Clive Taylor comes in, and he just wants to introduce himself and let everyone know about pathology. And the first thing he did is he walked in and he put up a picture of a city. But I didn't know what city it was. And he said, "Who knows what city this is?" It wasn't New York. I think that would have been too easy. And I was stumped. I mean, I didn't know cities at all. It turned out the city was Chicago. And he said, "How do you know this is Chicago?" And there's one building in that city that tells you it's Chicago. Anybody know what that building is? Sears. It's the Hancock building, right? At least that's the building that he showed. So I didn't know it, and somebody knew it, and they mentioned it, and he said, "You're right, but why?" So pathology is a study of disease, and many times when you're looking for disease and what causes it, you're going to mostly see normal things, right? And you have to have the eye to see the one thing that tells you what it is, that gives you the clue of what you're dealing with, right? And there's a name for that in medicine. It's called pathognomonic. Pathognomonic. And pathognomonic means it's a finding that you physically see, or some finding with a test that you do that tells you exactly what you're dealing with. And it eliminates all other likely scenarios or possibilities. So a pathognomonic finding. And that's what I focus on in my practice, the art of medicine and how to figure out what's wrong with people and what causes their pain. I look for pathognomonic findings. Things that once you see it, you know where the pain's coming from. And if you focus on that in every patient exam, you'll be able to determine what's causing that patient's back pain or neck pain. And I think that idea has been core to our success at Deuk Spine Institute in terms of diagnosing and then treating patients with back and neck pain. So with respect to your wife's condition, I would say if she has pain in her shoulder with rotation that then shoots down her arm, then I would be concerned about a shoulder injury. I suspect that's not the case though, because shoulder injuries usually don't cause numbness or tingling or pain in the fingers. That's a pinched nerve. But we could be dealing with a shoulder injury with a pinched nerve in the palm or the elbow, which is a common scenario. The pinched nerve in the elbow is called ulnar neuropathy. Pinched nerve in the palm is called carpal tunnel syndrome. There are other entrapments, syndromes of nerves in the forearm and the arm, like anterior interosseous nerve with interosseous nerve syndrome. So these are rare, but certainly possible, and you have to be aware of them to look for them when you're evaluating a patient. So that's why the physical exam is so important, and that's why the diagnostic imaging is so important. I need both to figure out what's wrong and then to act on it. Did I say 5 minutes 10 minutes ago? I lied to you. I apologize. This herniation just seems to go on and on and on, which is really challenging, but we're getting there. I think I'm close. I hear another question maybe coming down the pipe.
We do. We have a question. We have a viewer asking, what is the typical time for recovery for a surgery for a bulging disc, and how long would it be before I could swim or lift weights?
All right, great question from our viewer. I have to qualify the answer. So, whoever asked that question, and this applies to anybody with a herniated disc or bulging disc, okay? Number one, it really depends on what surgeon you choose as to how soon you're going to be able to return to your activities. When my patients have the Deuk laser disc repair like you're watching right now for a herniated disc, you can go back to activities literally the next day. Walking. What's wrong?
No, I just wanted to make sure you choose a match.
What was the specific activities that this person wanted to know about? Zach? I got distracted. I apologize. What were the specific activities?
Swimming and lifting weights.
So swimming, you can start swimming in 2 days. And lifting weights, you can start lifting weights in 2 days. But understand the weights that you lift are going to be light, under 25 pounds. So, by the way, we have patients who do CrossFit that have this laser surgery, and they end up going back to their CrossFit. So, it's definitely doable. Depends on your level of motivation. We work with all of our patients to get them back to full activity as soon as possible. What I can tell you is that if you have your disc herniation fixed with an open surgery, traditional microdiscectomy, it's going to be a lot longer before you can go back to your activities. And the surgeon's going to take away bone from your spine, which you really don't want done, because that's going to weaken the spine. The Deuk laser disc repair you're watching right now is the only surgery that's transforaminal. It's going to be able to fix your herniation without compromising the integrity of the bony spine. Transforaminal endoscopic surgery, that's the only way. Otherwise, all the other traditional surgeries are removal of bone. Yeah, so unfortunately I'm in the most painful part of his disc right now, and that's why he's responding, which is fine. We know he's doing well, right? And I really do hope to be done in less than 5 minutes at this point. Look at that herniation just popped out. Pretty cool, huh? Goodbye. So I hope I answered the question. I don't know if I did, but I tried to. You can go back to swimming in just 2 days. Just remember though, I don't want you like jumping off a cliff swimming. I don't want you swimming with great white shark swimming. I'm talking about getting in the pool and doing, some breaststroke, freestyle, whatever. Just not Olympic level swimming. You ever see that GoPro video of the guy that jumped off the cliff with a GoPro into the ocean? And there was a great white shark. Oh yeah, waiting. No joke. It was impressive. I don't know if he photoshopped that thing or what, but that was incredible. So there's the rest of the tear. You see the pink tissue? That's where the back pain comes from. So we got to zap it away. We're going to let all this heal now without the herniation, and it should heal fine. Great questions from our audience, by the way. What you're seeing on the right where the laser is, there's a little pink thing way over there at 3 o'clock. That's actually the end plate of L4. The L4 end plate. Now, why are we seeing the L4? Because we're closer to the L4 end plate. That's just fine. That's where the nerve is. We want to make sure the nerve is decompressed. All this is scarred up garbage from the herniation, all inflamed from, this is, 3 to 5 years maybe, this stuff. Great job so far, Luis. So let's see, I'm going to be done here in just a minute, and I'm going to come to your side, and we're going to get the fluoro back in for a lateral, right? And then we'll get those two herniations over there. Anybody know which side was worse for him?
He said both sides were
Equally bad, yeah. Well, that's fine. Are you using 4-liter bags?
3 liters.
Okay. By the way, you can see the view gets very cloudy at times, like right there. What you're actually seeing is all the disc herniation being vaporized into little pieces. And so it clouds up the view as it gets sucked up towards our camera. Pretty cool, huh? Yeah, this surgery is not available really in anywhere else. The Deuk laser disc repair is not at this time. But as I mentioned earlier, we are looking to open centers in other hospitals and other locations. So if you're watching and you want to have something like this close to where you live, just talk to me. We have to have a plan that makes sense. I'm happy to train surgeons how to do it. We have a turnkey opportunity where we come in and train everyone and set everything up. So it really takes little effort on the part of the administration of a facility. They just need to engage us and we do the rest. I get a lot of requests from people, can't you come to this country or this state or that state? Yeah, we'd love to. That's our goal. We want this surgery being done everywhere because it's an amazing surgery. And it's helped so many people get their life back without having open surgery, being able to go back to a normal life right away. All right, just about done here. There's just a lot of material just right where the epidural space is. Just going to finish this up. And this is right where the nerve is getting pinched as well. So I want to make sure we get rid of all that bulge. I have Dr. Santiago here with me, who's one of our fellows as well, and training with Dr. Patel and myself, mostly Dr. Patel.
We have a question.
Yes.
We have a viewer asking, are there any post-procedure arrangements that need to be made if they're traveling and live in a different state?
All right, are there any post-procedure arrangements that need to be made for people to travel from out of state or out of country? So the answer is yes. It's real simple. We don't need you coming back to the office because 99.9% of the time you're doing great. There's no issues. You just can go home basically the next day. And then we just want to talk to you on the phone and make sure everything's good. Now, what we do need is therapy, the proper therapy being done. That's the most important thing. So to achieve that goal, we need you communicating with the head of therapy, and her name is Dr. Schrumpf. Dr. Schrumpf heads up a therapy group called Florida Sports and Spinal, and they're in charge of all the therapy for patients. And I'm telling you, the therapy is so important. People who don't do the therapy still have muscle aches and pains after the surgery. So we strongly recommend everybody gets therapy after surgery for at least 4 to 6 weeks. And all that can be done over the internet. She does consultations over the internet. So we have patients who will meet with her over the internet, and she'll assess them and she'll guide them and direct them. And we help coordinate that. Aside from that, there's nothing else. There's no other meetings, treatment, tests, or anything that needs to be done. So of the 900 cases I've done, I have 9 patients with recurrent disc herniations, meaning that they did something after surgery, usually to make another herniation come. And aside from recurrent disc herniation, we've never had an infection, never had nerve damage, we've never had any other complication. So it's in a very safe surgery, it's outpatient. Those people who come from out of state or out of the country, you definitely need a family member or friend, somebody who's going to drive you to and from the facility and keep an eye on you while you recover for the next 24 hours after surgery. If you don't have anybody, that's okay. We can arrange for a family member. We'll be your family for you. Right? All right. Done. That was a tough one, a lot worse than I ever thought it was going to be. There's the nerve up in that fat up there. But yeah, that was really interesting. I just want to get a little bit more right here.
Hey, what happened to that one?
How are we doing, Luis? Good?
You're good, sir. Just want to make sure everything is okay.
Basically peeled away all the herniation.
You want to change the fiber for the next side, or
No,
want to continue with that one?
nothing wrong with this fiber. Why would you change it? Yeah. Yeah, that's what I'm talking about, though. Why don't we just strip it? Do you have a sterile stripper? Stand by.
Bring the stripper.
Right. We need a sterile stripper. All right, what is going on with this? Oh, I see. Okay, I need a nurse. Wait, I need a nurse with gloves. We're going to pull some of these blue towels right out of the bag because it's kind of weighing the bag down. You need just any glove.
Any gloves, any gloves.
Yeah, that's not considered sterile down there. Otherwise, I'd grab it myself. Just grab it and pull it. Just don't touch my cables. Yep, go. Up and out. Scope off. Yeah. Well, one day we're going to get to where we get it right.
We're finding out what's going on.
It's like an engineering project. Let go. Right? We need an engineer, a civil engineer, to create a way for the fluids to move into the bag and down the suction tube and out of the room, rather than on my shoes. So, for those of you wondering what we're talking about, endoscopic surgery. I'm going to throw this down. I'm actually not going to be on the side anymore. So endoscopic surgery is done with irrigation or fluid, lots of fluid moving through the tube. Whether you're doing a knee scope, shoulder scope, doesn't matter, spine, There's always fluid. So what's happening is the fluid has to go somewhere. We don't reuse it. It's not safe to do that. So what we do is it usually gets sucked up and ends up in the suction tube and then into the drain, right? Or in my case, it ends up on my feet. And my team has been working for years trying to develop. Oh, I think I touched the floor with my left arm. I need a sleeve. Luis, I need a sleeve.
Alright, that's clean. Hi, you go ahead and sleep, right? Alright.
We got a mic. Luis will need to take it from you. You need to stop what you're doing, Luis. You know how to put that on me?
I never put it on. I know.
Yep. All right, I'll show you. So come over here. No, over here. Okay. Yep, unfold it. Yeah. Just open it. Just kind of open it. Yeah. And now put your hands inside those flaps and open them wide. And I'm going to come in and come out the other end. Keep going, keep going. And now push those flaps that way. Yeah, yeah. Perfect. Keep going. Yeah. A plus. You did it, man. Congratulations. Go take a break. All right. So, anyway, you get to see all the things that happen in the operating room. Thank you. Because that's what I want. I want our viewers to have the full experience as though you were here with us through the good and bad. You just want to get it firm and then twist it around. All right, I'm going to do some fluoro shots. So fluoro, right there. All right, let's see. Shot. I can't really tell. And shot. Why is the shot so bad? Shot, I think you're wiggling. Would you stop that breathing business? And there. That should be it right there. Okay, I can see it now. This should all be sterile. Hey, don't move. You're doing good. Lay still. Is that it? Shot? All right. So, hey, don't move. Shot. Main thing here is I don't want to pull the guide wire out while I'm pulling the spinal needle out. Shot. So I'm going to keep taking pictures because if I accidentally pull the spinal needle, the guide wire out, shot, as the needle comes out, then I got to start all over. And that's not good. Not good for anybody. All right. Thank you. Don't wiggle around. Lay still. Okay, so that looks pretty good. I want to get down onto the annulus. There it is. Oh yeah, shot. All right, good. Yep. Shot. Again, our patient is gonna be uncomfortable right now because shot. Well, because honestly, we're going through the part of the disc that's really painful. Shot. Take. I don't like the fact it's rotated, but I don't think we have much choice. Take. Shot. Good. Tubular retractor. Sure. All right, for those of you who joined us late, Zach, can you see this?
Yes, sir.
All right, Dr. Santiago, can you do me a favor if you're not busy. Just turn the light so we can see the incision right over here. So we already did the right side, which is this is the right side of the patient. You all see that incision there, Zach?
We can see it.
And we did the whole surgery through a metal straw, basically. Right? So, right like that. So we're going to do the same thing on the other side. How common is it for us to do bilateral, or what we mean by both sides? Bilateral means both sides. Not common at all. You know, having bilateral surgery, probably 30% of the patients, maybe 25. Most patients have one leg that bothers them, right or left, and we go on that one side. But some people have bilateral symptoms. Shot. And I always give, what's the problem?
No, I just want to fix this over here.
Interesting. Okay, I like your experimenting.
Alright, let's try this one.
Absolutely. Any questions from our audience, Zach?
Not yet.
Ah, they know everything, huh? Okay. Is Dr. Michelle watching? Are you out there, Dr. Michelle? Give me a thumbs up. No, I think you're fine. Right where you are. Right where you are. Yeah, lower it would be good. Maybe if you can just move out of the way just a little bit. I can operate like this, though. Huh? That's fine. That's fine, yeah. Okay, let's get the scope on. I need to see the scope up there.
Handle, monitor.
There we go. Beautiful. All right, Luis. Moment of truth. You can just bring it off to the side. There you go. Yep, that way it won't fall down. Right? And then make sure it just goes in there. That's pretty. Beautiful. What a view. That's your annulus. Fibrosis. All right, let's get the laser in. I don't need a loop. Just give me no loop. Keep it coming. Perfect. I need the pedal at my foot if it's not already there. Is it? Yep, we're good. All right, laser on. All right. So, yeah. Whoa, watch that laser. No, don't trap it. It must release its energy in the right place. Watch the loop. So we moved to the patient's left side, right? We already did the right side. We moved to the patient's left side. And now I'm just working on their left side. The reason, they had a herniation that was on both sides. Two, as a matter of fact. One at L5S1, one at L45. How are we doing on the fiber? Are you happy? We got it fixed. Luis did his first stripping. Congratulations, Luis. Huh? He gets a 10. He's a professional stripper now. So what we're talking about, for those of you, before you call and complain to some entity, is at the tip of this laser you see a little glass clear tip. Well, that had broken off um, outside the patient. It was not inside. And that glass tip was short right up against the blue plastic that covers it. So I was using it standby, which is fine. Nothing wrong with it. I'm always going to bend it and give it to you. I was using it, which is fine, but as our very astute technician noted, the amount of energy that I was actually delivering was less than we wanted it to be, because the blue plastic was kind of blocking some of that energy. So hold on. So I agree, we needed to rectify the situation. All right, remember we're at L5S1, and I'm gonna start pulling back a little bit. Try to identify the tear. Grab her.
We have a question.
Yeah, we take the question.
We have a viewer asking, how long is the recovery time for this surgery if you were to do 2 levels?
How long is the recovery time for this surgery, Deuk laser disc repair, when you do 2 levels? It's the same recovery time. It doesn't matter if I do 1, 2, 3, or 4. It's all the same. It's usually 1 hour recovery. 1 hour. 1 hour, and you get to go home in 1 hour. Just like having a colonoscopy, except we're not working on the colon. We're just working on the spine. So it's very quick. And the reason it's so quick is I think you can appreciate the incision is very small. It's the width of half of a dime. And the patient's not under general anesthesia, so there's no general anesthesia for them. There's no tube down his throat. He's getting what's called total IV anesthesia, right? Just through the vein, intravenous, propofol. And he's wiggling around a little because we're in that painful area where the annular tear is at L5S1. So it's okay, everything's all right, just lay still. Okay, watch the loop.
Yes, sir.
So yeah, the recovery for this surgery is the same whether you do 1 level, 2 level, 3 level, or 4 level. The disc itself, once we operate on it like this, is going to take a year to completely heal. So what that means is that you're able to do normal activities, but you just have to be cautious about, standby, how much you're lifting. And I don't want people bending over in the first 6 weeks, bending over to pick anything up from the floor, bending over at work. All that needs to be, you need to hold off on bending for 6 weeks. So, but the recovery time is 1 hour. You literally go home 1 hour after the surgery. We looked at all of our patients, and the average recovery time was like 53 minutes. So just under an hour, actually. If you go to our Facebook page and watch the surgery from earlier this week, you can see that we did a cervical laser surgery. A patient that had 3 discs, 3 herniations, and if you're interested in the neck, most of our laser surgeries are on the back. People with back pain. Watch the loop, please. What are you doing over there? Luis, what are you doing?
I'm getting more rated, sir, but I'm watching the looks. It's too tight for you, or what's going on?
No, I just don't want it to hit my face.
Oh, no, it's not gonna happen, sir.
Once it hits my face, we have to get another one.
I understand.
Yeah, that's the risk of this job. I stand by. Listen, let me help you out. If you just grab right here, put your hand there, not there, down lower, you're always going to get the right spot. Does that make sense?
Yes, sir, but I watching also this side as well.
That side will always go right where it went, every single time. You understand? So really good questions so far from our audience. Any other questions?
We do have one actually. We have a viewer asking, can you do this surgery on someone who has severe scoliosis and sciatica?
All right, Zach, I heard, can you do surgery on somebody who has
Severe scoliosis and sciatica.
severe scoliosis and sciatica? Great question. So the answer is yes, we can usually do surgery like this on a patient with severe scoliosis and sciatica. I will tell you, the more severe the scoliosis, the more rotated the spine, the harder it is to reach those areas that need to be fixed. But the general answer I can give you is yes, not a problem, we can do it. Virtually every patient we do surgery on has some degree of scoliosis at the area that we're operating. So we're not fixing the scoliosis, but we're fixing their source of pain. I would need to see your films, whoever asked that question. And for anybody with scoliosis, I would need to see their MRI, X-ray, before I can tell you with certainty that I can do the surgery successfully. I'm not the kind of doctor who does surgery unsuccessfully. So I wouldn't just say, yeah, we can do your surgery, no problem. Of course, we could do surgery on anybody, but I don't do surgery unless I know I'm going to be able to fix a person's problem. Stand by. That's just how I operate. There's no point in operating on someone if they're not going to get better. So I would say if you're interested, send in your MRI for review or come here and get one done, and X-ray, and we'll sit down, we'll look at them together, I'll explain to you what your options are. Fact of the matter is, whoever asked the question, and just for the general audience to know, if you have sciatica, if you have scoliosis or not, it doesn't matter. You may not be able to get the laser surgery, which I don't think is going to be an issue, by the way, but I would be able to fix you with an open surgery. In other words, fixing a patient who has degenerative scoliosis associated with stenosis and sciatica is not a problem for me to do. It's very easy, but it may require open surgery with screws and rods rather than laser surgery. Either way, I can fix the problem. It just may not be with the laser surgery. So just so you know, this patient we're doing right now has probably about 8 degrees of rotation. So they have about 8 degrees of scoliosis. I don't know what your amount of scoliosis is, but I could probably do the laser surgery on somebody with up to about 40 degrees of scoliosis. If you have more than 40 degrees of scoliosis, I'd say it's going to be too difficult. Now, the other thing you have to consider is I'm talking about scoliosis right at the level you need fixed. So let's say you have scoliosis in your upper spine, but you need to have your lower spine fixed. Then the scoliosis in the upper spine doesn't matter. It won't affect our ability to fix your problem. So what I'm talking about is scoliosis at the level where we're operating. I hope that's clear. So once again, if the scoliosis is remote or distant from the area we're operating, then it's not a concern. We can certainly do the laser surgery. If, on the other hand, the scoliosis standby laser is at the level of the disc herniation and stenosis causing sciatica, then I can do it with the laser up to about 40 degrees maximum of scoliosis. Nice job, Luis. It's there. Yeah. Everything okay, Dr. S? That's fine. All right, so we're just about at the end of this one. Again, this is the patient's left L5S1. How are we doing on irrigation? So you never want to get too close to your scope with your laser. Ooh, nice. Stand by. All right, I'll give it to you the same way. Because you can actually blast the lens right out of the scope. And that's going to suck really bad. Because then I got to take it out of Dr. Santiago's paycheck.
That would be really bad.
It would be really, really, really bad. I'm kidding. I don't want people thinking I'm cruel and heartless. Just cruel. You like that? I do try to inject a little humor now and then. It's not easy. I am a neurosurgeon after all. Watch your loop. We're just about done. I'm feeling like there's an awful lot of bubbles. Am I mistaken? Did we just do a switch? Okay, yeah, there's a lot of bubbles. Which side does he use his cane? Right? I think it's his right. It was on the right side of his bed. I suspect it's the right side that's worse. Stand by. Zach,
Yes, sir.
awfully silent over there.
Not any more questions yet.
Oh, please. Are you serious? An audience without questions?
You know everything.
That's what worries me. I'm sure we're going to be hearing about Deuk laser disc repairs being performed all over the place. Now that I've made all of them experts.
When the reality show starts,
The reality show?
yeah, it sounds like
We're doing a reality show right now.
but I mean, with the channel and everything.
Okay, Luis is saying we should do a reality show where we basically would do a Duke Spine Institute reality show. And we would just broadcast every day, constantly, what we do here. Which I'm fine with, by the way. But I don't know if anybody has that much interest in learning how to fix back and neck pain, do they?
There's a reality of everything. Like
Don't move. Yeah, listen, I've always wanted to educate the public on the cause, the treatment, the diagnosis, the management, Everything. Oh, yeah, that's painful for the poor guy. There's some serious. See those? All this area right here. Herniated disc, interposed nucleus. Just about done. 3 minutes. You're doing good. Just lay still. How many cameras do we have that are operational?
Lumbar?
Cameras. Cameras.
Oh, cameras, we have 4.
4.
Yeah.
Do we have any that are not working?
No, everything.
They're all working. That's one of the biggest problems. Standby laser. Sorry, let me get to the other way.
Yep.
Is that these companies have what's called planned obsolescence for their equipment. Take it. This should be it right here. Any other questions from our audience? You're watching live spine surgery. We're broadcasting from the Deuk Spine Institute and Surgery Center of Viera here in Melbourne, Florida. You're watching a Deuk laser disc repair on a patient who has back pain and pain in both legs. And we're pretty much done with this level. I believe we're at L5S1, yeah, right? On the patient's left side. This is all epidural stuff right here. That. Okay, question from the operating room itself. Does the disc grow back? That's a question. No, the answer is absolutely not. The disc does not grow back. Everything in here. So, actually, let me qualify the answer. The nucleus pulposus, the jelly that came out and caused all this problem, well, actually, the annular tear was the first thing, but the nucleus pulposus never grows back. The annulus fibrosus is going to heal. And it won't grow back exactly as the annulus. It'll grow back as basically collagen or scar tissue. So, but that's how all annular injuries heal in every human being, is scar tissue, collagen. And it doesn't cause any pain or symptoms. So I expect it not to cause problems for him either. Laser off. Let's see if we can see the nerve better. There's the nerve right there. Look at the blood vessel on the nerve pulsing. That's pretty cool, huh? Yeah, so there's a little arteriole that runs out with the nerve, a little artery and vein. And that arteriole is pulsing on the wall. It's at 9 o'clock. 9 o'clock. Pretty cool. But that's your nerve right there. That's going to be the left L5 nerve root. Okay. Take it. I'm not ready for this. I have to get all the juice out. That red stuff is blood. I wish I had that little cap right here. Man, I don't understand. There we go. All right. Scope off. Needle down here. Oh no. All right, we're going to get this tube out. Okay, good. So far, so good. 3 down, 1 to go. This is a longer case because we're doing 4 herniations. 2 discs, but 4 herniations. Huh. You can see all the fragments of herniation right here from that last level. Okie doke. You got it, Luis? Hold it. Gonna put our guide wire back in for the last time. This will be our last disc. 4 out of 4. And then we'll be done. We'll get the patient recovered. Shot. Bam. Nice.
Do it again.
Huh?
I will do it again.
Yeah. Yeah, we have another one, don't we?
Yeah.
What, how many levels is the next one?
Same side.
Oh, thanks. Just kidding. I'm ready to rock and roll. I might have to call Dr. Patel in to help me out. Oh, he's doing an RFA in the next one? All right. Whatever Dr. Patel wants to do. Doesn't matter to me. Let's see what Dr. Patel wants to do. I don't know. Shot? Yeah, just ask him. You know, I'll work around his schedule. Shot? He's a busy man.
I'm sure he would like to do it before.
Then we'll do it before.
Most likely.
He needs to go to his therapy session. All right. All right. Don't make me laugh on an empty stomach. The funny thing is he actually goes. All right. Shot. Dr. Patel, you know I love you. Shot. All right. I think the guide wire is moving forward, but we're done with it. I think we're nice and in good. Take this in good position. Shot. That looks good. Again, the whole surgery, for those of you joining us late, being done through a little metal McDonald's shake straw. I wish it was that easy, but these straws actually cost about $2,000. And yes, they actually get bent sometimes, and we have to replace them. That's when my family doesn't eat for a week. Shot.
So my
So now I worry about my family now.
What is it? Huh?
I worry about my family now. With the,
Right. I'm sorry, let's see. Yeah, let's go ahead and take fluoro out. I think that's a great idea. Need to go for my bike ride today. All right, I'm gonna come in. What an elegant surgery this is, huh? I mean, people think about spine surgery as being so damaging, and this is just incredible to be able to do all this through just a tiny incision. I didn't develop the approach, which is called transforaminal. What I developed is some of the strategies once I get here. Take it. What I do with the laser, which laser, it's different than what other surgeons that train me in endoscopic surgery do, but I believe it gives better results. All right, this is it, folks. So if you have questions, ask them. Don't be shy. Don't be bashful. We're in the herniation right now, deep inside, right at the base of the herniation, right where, if you think of the tip of the iceberg, this is the base of the iceberg, the opposite side of the tip. And to get to it, I went straight through the iceberg to get to the base. So that's kind of what we're doing here. So you can see a lot of scar tissue right there, a lot of collagen. This is all nucleus though. Nucleus pulposus. Yes, we have another question. What's the difference between a herniated disc and a ruptured disc? There's no difference. They're all the same. Herniated disc is the general term. Ruptured is another. Extruded, bulging. They're all the same thing. Really, they're the same thing. Okay, so people say, well, why do they have so many different names? Usually what they refer to is the degree of the amount of herniation there is. Like, is it a big herniation, a little herniation? He's moving. A bulge is what we call a contained herniation. So it's still a herniation for sure. The jelly has come out through a tear in the annulus. It's just that it hasn't gone very far out. It's just kind of poking its head out. Think about it like a little gopher, right? Sticking his head out of a hole. The fact that he's sticking his head out of the hole is a herniation, right? But for him to come completely out of the hole is an extrusion. And to get stuck where he can't get back in the hole is a sequestration or a migration, like a migrated disc or sequestered disc. Does that make sense?
Yep.
But the fact that the gopher pokes his head out of the hole tells you that you got gophers. So you better do something about it. Call Bill Murray.
So if I hang on a version table, will herniation go back into place, or?
If you hang on an inversion table, will the herniation go back into place? It may go back in just a little bit, but not significantly in my opinion. So people feel better when they get on an inversion table for a little bit, but then gravity pulls their body down and it ends up pushing that herniation back out. Now, if you stayed on an inversion table for about 6 weeks without getting off, you might be able to. Listen, I had a patient years ago, poor woman. She got into a car accident in France. Nothing against France, by the way. I love France. She was admitted to the hospital with a herniated disc in her neck, too, actually. And they put her at bed rest for 3 months. 3 months of bed rest for a herniated disc. When I could have fixed that in an hour and then put her back in her normal life by the next day. It's sad. I mean, that is really what waked me up to the fact that so many, depends on where you go. That's what kind of treatment you're going to get. Literally, had that woman come to me, I would have fixed her that day, sent her home the next day, back to work 2 days later, back to normal life. But instead, she spent 3 months laying in a bed in a hospital. That's how they treated it. Is that not insane?
So that never really
Oh, she ended up getting surgery with me, right? So it never, the bed rest doesn't work. That's why we don't recommend bed rest anymore. But I guess some people take a little longer to find things out. Again, nothing against France. It's just, and by the way, that kind of stuff happens in the United States. I mean, and if insurance companies have their way, that's how they're going to treat all people's spine problems. Just tell them to go home and just live with it. Not pay for anything. Go home and take medical marijuana so they get out of the responsibility of paying for the patient's treatment. That's what they want. For those of you wondering why I badmouth insurance companies so much, aren't they paying for the surgery? The answer is no, they're not. This patient paid for his own surgery. Standby laser? That's because he believes in this technology. All right, I think we're going to be done in 10 minutes, if that helps you. Oh, that's a nice herniation fragment. I don't know if I got it all. I did not. Take. All right, any questions, Zach?
Not yet.
How's our viewership today?
It's not too bad. Pretty normal. Just not a lot of questions.
It's because everyone's running out to get their popcorn and drinks, right? Yep. So this is probably the last big piece of herniation that's deep. I'm going to start moving out to the periphery of the disc next. I don't want to spend too much time real deep inside. Really need to get to the outer part of the tear. And you can see most of the blue dye has kind of started to dissolve away. I think we got our end plate over there. And again, this is a disc where we were talking about earlier on the other side where there's been there's a herniation. Just major damage, standby laser. Major damage to it. I don't know what happened to this gentleman. I don't know if he fell. He is using a cane, but I got it. Okay, just lay still. Wipe. That looks good. But whatever injury he had to this disc was pretty severe. This is no normal herniation. This is like a massive pressure down on the disc, causing almost like an explosion within the disc. There was an old terminology for it, which we don't really use anymore. It's called internal disc disruption. And I didn't describe that first. That was done by somebody else, but it basically characterizes an anatomical finding of where the entire inside of the disc is just looks like a bomb went off. And that's kind of what I'm seeing, at least what I saw on the other side. And it never looks that bad on the MRI. The MRI usually looks pretty good. But once you get in to the disc and you can see it with the endoscope, you can see all the damage that was done. So it's easy for doctors to miss it if you just rely on the MRI. And quite frankly, if you look at this patient's MRI at 045, you won't see it. You're just going to see a herniated disc. Looks like every other standby herniated disc. You won't see this massive injury. But now that I'm inside the disc, I see it. I don't see a lot of them, to be honest with you. I only see it once in a while. I used to see it more when I was doing patients that were injured in car accidents. You'd see the disc just massively traumatized. Did this patient have a car accident? Do we know? We don't know? Uh-huh. Well, he may have had a fall or something. So, sometimes people don't like to talk about their problems.
We have a question.
Sure.
We were asking, is the laser surgery always the better option, or are there any cases where a fusion would be a better option?
Yeah, it's a really good question. Is laser surgery always the better option, or are there any cases where fusion would be a better option? So in my 20 years of experience doing this, I'm going to give you a number you can remember. 95% of fusion surgeries could be replaced by the laser as a better option. About 5% of fusion surgeries that are being done currently could not be done with the laser. All right, so what kind of cases would be better for fusion? Well, to understand that, we have to ask, why is fusion done? Fusion is done for the same reasons laser is done: back pain or neck pain, leg pain, and arm pain. All right? Well, what causes the back pain for a fusion patient? It's the same thing that causes the back pain for a laser patient. Right, what we're fixing right now, the herniated disc. So it's the herniated disc, the annular tear, really the annular tear, that causes the back pain in fusion patients. And it's the annular tear that causes the back pain in laser patients. So there's no difference in the cause of the back pain. Okay? Now there is a situation where the laser won't work. And that's if the patient has what's called facet pain. So if you're doing the surgery because the patient has pain from their facet joint, then you're right, it's not going to work, because I'm only operating on their disc. So fixing their facet joint with a fusion surgery by removing the facet joints or stabilizing the facet joints would make a fusion surgery a better option. But here's the deal. We don't do this kind of surgery on patients with facet pain. We do this kind of surgery on patients with disc pain. So I'm always very careful with my patient selection to select patients, like I said earlier, that I know are going to get better with this surgery. Would you have Sandy come make a fresh pot of coffee, please? I really need some coffee. Not because I'm tired, because I'm just craving that taste. Good old Folgers coffee. Never thought I'd be a Folgers coffee drinker. Never in my lifetime. You know?
And you are?
But I'm thankful that I like Folgers coffee. and not just Starbucks. Nothing against Starbucks, but Folgers is a lot cheaper and more accessible for me, at least. So yeah, to answer your question, 95% of spinal fusions, and by the way, how many are done every year in the United States? 500,000. There's 500,000 fusions done a year in the United States. Half of the 500 million, pardon me, 500,000 spinal fusions every year in the United States, cervical and lumbar combined. And all of those, 95% of them could be this surgery instead. Just think about the opportunity to improve healthcare right there. Just right there, one procedure, one surgery, one problem. That's massive, massive impact. And by the way, this laser surgery is 1/4 the price of a fusion. So imagine how much money could be saved by doing this surgery that works rather than a fusion. And think about how fast people could go back to work. My God, they could be back to work within a day rather than taking 6 months off or even dying from their surgery. Standby laser? I think we're pretty much done. I could see the dura. I don't know if you guys saw it. It was at 12 o'clock. You can rewind your film and see it. But yeah, we're there. Just want to clean up the last few bits. And I'll see if I can show you the dura real quick. We're just underneath the nerve root. And I mean the traversing route. I'm not talking about the exiting route. So look, let's see if I can find it again. Oh, I don't see it now, but it was up there on the roof.
We have a question.
Yeah.
We have a viewer asking, when you tell the patient to lay still, are they awake enough that they can actually understand what you're saying?
Yeah, when I tell the patient to lay still, it's tongue-in-cheek, if you understand what I'm saying. Basically, it's just I'm being cute. The patient's not awake. So why are they moving, you may wonder. The reason they're moving is a reflex, okay? So if you're sleeping and I take an ice pick and stick it in your foot, you're going to pull your foot away really quick without even thinking about it because it's a reflex. It's subconscious. It goes from the sensory nerve fiber to the spinal cord and right back to the what are called the effector organ, which is your muscle. In other words, it's a reflex. He's not awake. But I just kind of joke around a little bit with you, the audience, and with my colleague, my anesthesiologist here, by pretending. So I do have some dark humor. I'm sorry. God made me that way. But no, the patient's definitely not awake, and they will not remember anything I said, and they will be just perfectly fine. So don't you worry one bit about them. Here. I don't like that. There we go. Last thing in the world I want is that piece to come out. I think we're done. I'm just going to zap this blue stuff so it doesn't make its way out later. And then I'm going to take one last look at the 12 o'clock position and our epidural space, and we're done. That was a great question, by the way. Thanks for asking. Yeah, I just kind of a little bit of humor, that's all. I'm kind of ribbing my anesthesiologist is what I'm doing. He knows it. He's too smart, though. He knows that he knows the patient's not awake. But that's kind of like how a surgeon can give an anesthesiologist a hard time, is that, you know, like nurses, they know how to give doctors a hard time. They just call you all through the night and tell you the patient has gas. What should I do? And then you're like, just leave me alone. I don't care what you do. Stick a cork in it if you have to. That's kind of like we're so exhausted and they're calling us about something ridiculous. So I'm giving my anesthesiologist a little call, like a little jab. And he knows that the patient's not awake, and he just smiles under his mask at me. And he says something in Spanish like, "You crazy surgeon." Let's see, I think that's it. Just a tiny bit. How's he doing?
He's doing great.
Ready to wake up?
Very soon.
Good. See, the thing about Dr. Santiago is he always has the right answer. Literally, he has the right answer. That's one of the things that impresses me about him. His confidence. Perfect. See, almost there is the perfect answer, but he's kind of teasing me a little bit. And he knows it, and I know it. See.
5 minutes are never good.
That's it. He says I need to be better at my estimates. He's right. I do. But he's joking at me too, because the surgeons always want their patient to wake up exactly the moment they're done. And of course, that's a completely unrealistic expectation, because the anesthesiologist can never tell when the surgeon really is really done. And even if they could, they couldn't time it perfect so the patient is awake exactly at that moment. So what the surgeons ask for is impossible, but of course the anesthesiologist won't say that to the surgeon. They'll just say, "Yes, he's right there, ready for you, surgeon." All right, take it. And yeah, look at the nerve right there. Beautiful. Okay. Beautiful. So we're just underneath it. All right, we are done. That was the traversing route. And let's go ahead and wrap this case up. All right, we completed the entire surgery. Bilateral 4-5-5-1. And I'll put our last bit of medicine. And Zach, you can take a look here. Yeah. If you want, show our audience the 2 incisions, one on each side for this patient. As we break down the equipment, put pressure. Yeah, go ahead. So pretty cool. Now, if you don't have problems with both legs, you don't need to go on both sides. And Luis will show you what he's got. Great job, everyone. Really, really good teamwork. It's funny, I'm looking at his MRI at L4 right now. L4-5, I see a big, like dark, almost like a tear in the middle of the disc. And maybe a hint of the internal disc disruption. All right, we do have another laser surgery coming up in about an hour. So take a restroom break. For those of you who want to stick around, I'm going to come answer questions with Zach. So I'll be there in about 5 minutes. So type your questions up, and I'll come talk for a little bit more. And then we'll take a break, and we'll have one more laser surgery a little later. Thanks for watching. All right, Dr. Deuk Majin, founder and CEO of Deuk Spine Institute, along with Zach. And we are not chasing giants. We are here to answer your questions about anything related to the topic of spine care, contemporary, modern, advanced, old-fashioned, whatever you want to ask about, whatever comes to mind. Therapy, surgery, pain management, causes, effects, tests. Listen, the sky's the limit. We're here to answer your questions and educate the public. So that's our mission, and to make everybody aware of what's available. And don't settle for living with back pain the rest of your life. You don't have to. You know, improve the quality of your life. Get your back fixed. Get your neck fixed if it's a neck problem. So our first question.
Is there a maximum age for it to be safe to have this surgery?
Is there a maximum age for the surgery in order for it to be safe? The answer is no. There's no maximum age. There's really no minimum age. It's really all about fixing a herniated disc if that disc is causing the problem. And my job is to figure out, first of all, is the herniated disc the cause of your pain? And if it is, we can do the surgery to fix it. It doesn't matter how old you are. It doesn't matter if you have degenerative disc disease, if you have a bulging disc, a herniated disc, a ruptured disc, an extruded disc, a migrated disc, a sequestered disc. It doesn't matter. They're all the same. They're all problems with the annulus and herniation that can be fixed. So what matters is not age. What matters is what's called the medical risk stratification, which is a fancy schmancy term for saying, are you going to die or have a problem during surgery or shortly after? And as long as we optimize our patients and make sure they're safe to have this surgery, then we've done everything we need to do. It has nothing to do with age. Come in. It has everything in the world to do with the condition of your heart and lungs and your blood. So just as an example, we have a patient who has blood thinners, right, for the blood clot they had from years ago when they had surgery. Well, that patient's on blood thinners, and it's not safe to proceed with surgery of this type when patients are on blood thinners. So the blood thinners are an issue. We won't do surgery when somebody on blood thinners. So they have to be able to get off the blood thinners for surgery. Most people are able to get off for a week or two, and then we do the surgery. No problem. So age is not a restricting factor, but blood thinners are. Another example would be if somebody had a low ejection fraction from their heart. In other words, their ejection fraction was just too low, they weren't pushing enough blood, and they would end up having a stroke from the surgery. We can't have that happen. So we would not do surgery on that patient with a really low ejection fraction, say below 20%. Okay, I'm just using that number. Another reason we can't do surgery is, for example, in the neck, I need to be able to feel the spine with my fingertips. If I can't do that because someone's neck is too thick, that's a reason not to do the surgery. So we call those contraindications for surgery. The contraindications for Deuk laser disc repair, there are many of them, but they're kind of unusual, rare things, and most of the time people can overcome them. So when you ask about those patients that are not good candidates for Deuk laser disc repair, those patients that have anatomical or physiological problems, like their heart doesn't put out enough blood, or anatomical, like their neck is just way too thick, those are reasons not to do the surgery. But age is never, ever, ever a reason not to take care of somebody. We do not discriminate based on age. Nobody should. You know, it doesn't matter if you're young or old. You should have access to the finest care available in the world, and especially in the United States, and it doesn't matter the age. So we operate on everybody that needs surgery. We operate on, people who are old, people who are young, people who are overweight, people who have hepatitis, people who have AIDS, HIV. We've operated on. We don't discriminate against anyone for something that's completely out of their control. Now, that's just our policy. We're here to help people, not to be a reason for them not to get well. Next question. How much pain relief would you expect the patient to have after surgery? I honestly expect them to have 100% pain relief. 100%. And that's typically what we get. You know, the fact of the matter is that back pain and neck pain, spine pain have a cause or causes in most cases. I'm going to tell you a little bit about a patient who just had laser surgery. This patient actually came to us with bad back pain, but their pain was all over. It kind of went from the top of the lower back to the bottom. So we did some tests. We got a X-ray, MRI, and one thing I noticed was they had really two major problems. One was a fracture of the L1 vertebral body, a compression fracture basically, which is not a common problem, but it does happen, especially in elderly people with osteoporosis or osteopenia. The other problem they had was herniated disc at L4-5 and L5-S1 with pinched nerves. So I talked to the patient a little bit. I said, what really bothers you the most? And they said, well, you know, I've got equal pain up higher and down lower. I said, well, listen, you got a fracture. I honestly think we should fix that first. So we fixed the fracture, and we did what's called a kyphoplasty. It's done with a little needle. We put some plastic cement in the bone that's fractured. It keeps it from getting worse. Patient did fantastic. All the pain up there at L1 went away completely right after the kyphoplasty, which is typical, 100% pain relief. However, they said they still had the pain in the lower back down by the belt line, down by L4-5 and L5-S1. It wasn't a surprise to me. And we knew that was going to happen because we didn't fix the disc down there. All we fixed was the fracture up above. So two different problems, both cause back pain, two different treatments. Okay, you got to get it, got to understand this concept. If you leave here and never come back again, it's okay. Just take away a message with you. That message is most people's back pain comes from multiple sources, more than one source. So that's why it's been so difficult for doctors to figure out how to cure it, because they just get bound up with one source. They don't think about the others, when actually at least 50% of our patients with chronic back pain have more than one source of pain. So anyway, this patient went on to have Deuk laser disc repair. How are they going to do with the Deuk laser disc repair at L4-5, L5-S1? We're going to find out right soon. So what do I expect? I expect 100% relief of their back pain, and I expect 100% relief of their leg pain. And that's what I think this patient's going to have. That was our last question. And, you know, we're here to help educate the public, and hopefully spine surgeons and spine care doctors and chiropractors and anyone that wants to listen. You know, we're not just here for healthcare providers, we're here for the general public. These surgeries are broadcast live across the internet, around the world, on 3 platforms: YouTube, Periscope, and Facebook. We chose those 3 because we thought between those 3, those are 3 good platforms that lots of people have access to, and that if they see something they're interested in, they want to watch it again, and they want to tell their friends or family about it, they can do that, and other people can watch too. So those are the reasons we chose those platforms. We'll continue to broadcast live and answer questions as long as we can. I'm Dr. Ara Deuk-Machen, CEO and founder of Deuk Spine Institute, and I look forward to helping you and educating you in the future. We got another surgery coming up in about 45 minutes to an hour.